proceed. Hi, it's Dr. Obasundubisi again, and we are continuing our discussion on respiratory physiology. And today we're going to be looking at pulmonary circulation under the following outline: pulmonary blood vessels, pulmonary artery, bronchial artery, the physiological shunt. We're also going to be looking at characteristic features of pulmonary blood vessels, pulmonary blood flow, pulmonary blood pressure, measurement of pulmonary blood flow, regulation of pulmonary blood flow, the cardiac output, vascular resistance, nervous factors, chemical factors, gravity and hydrostatic pressure. And we're going to be using as our source, essentials of medical physiology. The pulmonary blood vessels include the pulmonary artery. Pulmonary artery carries the oxygenated blood. It's unique in doing that because other arteries carry what? Oxygenated blood. Yeah, pulmonary artery is unique in carrying deoxygenated blood. That's a good MCQ question. To alveoli of the lungs now and bronchial artery, which supply oxygenated blood to other structures of the lung. Now, like we said, the pulmonary artery supplies the oxygenated blood pumped from the right ventricle to alveoli of the lungs. Okay, so this is pulmonary circulation. And while the pulmonary vein carries what? Oxygenated blood. Now, after leaving the right ventricle, the pulmonary artery divides into the right and the left branches. Now, each branch enters the corresponding lung via the hilum with the primary bronchus. Okay, so after entering the lung, a branch of the pulmonary artery divides into small vessels and finally forms the capillary plexus. It's the capillary plexus that is in intimate relationship with the alveoli, and that is where gaseous exchange occurs, which we're going to see very soon. Now, the capillary plexus is solely concerned with alveolar gas exchange. Now, oxygenated blood from the alveoli is carried to the left atrium by one pulmonary vein on each side. The bronchial artery arises from descending thoracic aorta. Now, it supplies arterial blood to the bronchi, connective tissue, and other structures of the lung stroma, the visceral pleura, and pulmonary lymph nodes. Please, the bronchial artery arises from descending thoracic aorta. Now, the venous blood from these structures, that's the lung stroma, the visceral pleura, and the pulmonary lymph nodes, are drained by two bronchial veins from each side. Now, bronchial veins from each side drain into the azygos vein. Okay? And the left bronchial veins drain into the superior hemiazygos or left superior intercostal veins. Now, the bronchial veins from each side drain into where? Azygos vein. Yes. And then the left bronchial vein drain into the superior hemiazygos or left superior intercostal. Sorry, the bronchial vein from the right side goes to the azygos. Yes. Now, the blood from the distal portion of the bronchial circulation is drained directly into the tributaries of the pulmonary veins. Please, let's get it clear. The bronchial veins from the right side go to what? Azygos vein. The left bronchial veins go to the superior hemiazygos, yeah, or the left superior intercostal veins. Now, from the distal portion of the bronchial circulation, the blood drains directly into the tributaries of the pulmonary vein. A quick recap. The bronchial artery arises from the descending thoracic aorta. So I'm sure we've got this. So there's a physiologic shunt that is defined as a diversion through which the venous blood is mixed with the arterial blood. Now, the components of this physiologic shunt, there are two components. There is flow of deoxygenated blood from the bronchial circulation into the pulmonary veins without being oxygenated. That is from artery to vein. Pulmonary artery carrying deoxygenated blood, pulmonary vein carrying oxygenated blood. There's a flow of blood through that bronchial circulation without being oxygenated. This makes up a part of the normal physiologic shunt. Then there's the flow of deoxygenated blood from the Thebesian veins into the cardiac chambers directly. Okay? So remember what we said, that the pulmonary artery supplies what? Deoxygenated blood from the right ventricle to the alveoli. Good. Now, there is venous admixture. Now, physiological shunt, this physiological results in some venous admixture. And this venous admixture refers to the mixing of deoxygenated blood with oxygenated blood. Okay? There are some fraction of venous blood which is not fully oxygenated. And this is referred to as wasted blood. Now, understand what we are saying here. We are saying that even though normally the right ventricle is going to pump blood via the pulmonary artery, deoxygenated blood, and pump it to the alveoli to be oxygenated and then released into the pulmonary vein, and then comes to the left atrium, down to the left ventricle to be pumped around the body as oxygenated blood. Okay? There are times when there is a mixing of deoxygenated blood directly with oxygenated blood. And this is the venous admixture. This can occur via what veins? The Thebesian veins, yes, by which the deoxygenated blood goes directly into the cardiac chamber. Okay? And it can also occur via the bronchial circulation, whereby deoxygenated blood in the artery flows and finds its way into the veins, which are normally containing oxygenated blood. Now, this normal physiologic shunt of venous blood from the right side of the heart to the left side is about 1 to 2% of cardiac output. In normal persons, it may increase to 5% of cardiac output, which may be due to a ventilation-perfusion ratio mismatch. Now, we have talked of ventilation-perfusion before, and well, just remember our discussions on ventilation-perfusion ratio. A pathologic increase in this shunt can occur. This is normal in most people. 1 to 2% of our cardiac output experiences venous admixture physiologically. No issues. However, pathologically, it can occur in pulmonary infections, in bronchiectasis, in which there's a permanent dilatation of the bronchi, due to chronic pulmonary infections. Now, so let's look at this physiological shunting of venous admixture and physiological dead space. We've talked of dead space, and we've talked of physiological dead space. What do we say about physiological dead space? Yes. Physiological dead space is non-functioning part of the alveoli, yes, or the part of the alveoli that is not well oxygenated. Yeah, so that's what we said. Now, this physiological shunt is analogous, is similar to the physiological dead space in the sense that gaseous exchange is not occurring dead space concept is such that gaseous exchange is not occurring. Remember, the anatomical dead space is the nose, the larynx, the trachea, the bronchi. No gaseous exchange is taking place there. Now, physiological shunt includes wasted blood, and physiological dead space includes wasted air. What is wasted blood? Wasted blood is the fraction of venous blood that is not fully oxygenated. Okay? And so both wasted blood and wasted air exists on either side of alveolar membrane, and this can affect the ventilation perfusion ratio. Remember, we said in chronic obstructive pulmonary disease, the ventilation perfusion ratio is what? Is decreased. Yeah. Now, characteristic features of the pulmonary blood vessels. Now, the features of pulmonary blood vessels that help them in gaseous exchange include the pulmonary artery has a thin wall. Its thickness is about 1/3 of the systemic aortic wall. Now, the wall of the other pulmonary blood vessels are also very thin. Why? Gaseous exchange. Pulmonary blood vessels are also very elastic, and they are more distensible. Why? Increased blood flow. The smooth muscle coat is not well developed in pulmonary blood vessels. Therefore, the true arterioles have less smooth muscle fibers. Now, the pulmonary capillaries are larger than the systemic capillaries. So when you think about the characteristic features of the pulmonary blood vessels, think about any feature that can help gaseous exchange. The vascular resistance in the pulmonary circulation is very less compared to the vascular resistance in the systemic circulation. It's only about 1/10 of the vascular resistance in the systemic circulation. So pulmonary hypertension is a big deal. Pulmonary hypertension is a big problem. Now, pulmonary vascular system is a low pressure system. Pulmonary arterial pressure and pulmonary capillary pressure are usually very low. Pulmonary artery carries the oxygenated blood. We have said that before, while pulmonary veins carry oxygenated blood. And then a physiological shunt is present. The deoxygenated and oxygenated sections, they mix. Now, in discussing the characteristic features of pulmonary blood vessels, like I said, you're thinking of features that can make gaseous exchange easier and more effective. Let's take them again. 1, the pulmonary artery has a thin wall. Its thickness is about 1/3 of that of the systemic aortic wall. 2, the pulmonary vessels are highly elastic so that they can be distensible in case of need for increased blood flow. Their smooth muscle coat is not very developed. Of course, that's why they can easily distend. The true arterioles have less smooth muscle fibers. And the pulmonary capillaries are larger than the systemic capillaries. And the vascular resistance in pulmonary circulation is what? Is very much less. Then the pulmonary vascular system is a low pressure system. And the pulmonary artery carries oxygenated blood, and the pulmonary veins carries oxygenated blood, and the physiological shunt is present. I hope this will be easy to remember. Just think of anything, any feature that can make gaseous exchange to be more effective. So the lungs receive the whole amount of blood that is pumped out from the right ventricle. And then the output of blood per minute is same in both right and left ventricles, about 5 liters. So when the left ventricle contracts, it sends about 5 liters of blood per minute into the systemic circulation from head to toe. When the right ventricle contracts, it sends out a similar amount of fluid, of blood. about 5 liters, into the lungs. So the lungs accommodate amount of blood which is equal to the amount of blood accommodated by all the other parts of the body combined. Pulmonary blood pressure. Now, because the lung has to accommodate the same amount of blood that the entire body has to accommodate from head to toe in a minute, it means that God, being a good God, has made the lung system to be a very low pressure system. That's it. Now, how is it that the lung system is a very low pressure system? What makes up blood pressure? Vascular resistance. Yes. And the vascular resistance is generated by the smooth muscle of the blood vessels. Yes. Now, there's a high vascular resistance in the systemic circulation. In the pulmonary circulation, there's a low vascular resistance. 2, elasticity of the vessels or distensibility of the vessels. Now, in the systemic circulations, the vessels are not all that distensible. Yeah. But in the pulmonary circulation, they are more distensible. So the blood pressure is less in the pulmonary blood vessels. Thus, the entire pulmonary vascular system stays as a low pressure bed. Now, let us see the systolic pressure in the pulmonary system and the diastolic pressure. The systolic pressure in the pulmonary system is 25. The systolic pressure in the systemic circulation is normally 120. The diastolic pressure in the pulmonary circulation is 10. The diastolic pressure in the systemic circulation is normally 80, or a range 80 to 90, while systolic in systemic is a range about the 120 to 135, 120 to 40, or 140. So you can see what we mean when we say that the pulmonary circulation is low pressure. It's on a low key, really on the low. Now, the mean arterial pressure, therefore, is 25 minus 10, which is 15. But the mean arterial pressure, the map of the systemic circulation, is about 120 minus 80, which is 40. Now, so the pulmonary capillary pressure is about 7 millimeters of mercury. And this pressure is low enough to permit exchange of gases. Now, how do you measure pulmonary blood flow? It's measured using the Fick principle, but the Fick principle is beyond what we're discussing here today. It's a bit complex and maybe we'll see it later. Now, what are the factors that regulate pulmonary blood flow? Factors regulating pulmonary blood flow. I've mentioned one, which is vascular resistance. Low vascular resistance, like we said. Another factor is the cardiac output. Others include nervous factors, chemical factors, gravity, and hydrostatic factor. Now, of course, if cardiac output increases, pulmonary blood flow increases. So pulmonary blood flow is directly proportional to cardiac output. So anything that makes cardiac output to increase also makes pulmonary blood flow to increase. What can make cardiac output to increase? Sympathetic response, fight, fright, flight response. Cardiac output increases. Cardiac output is regulated by venous return, force of contraction, rate of contraction, and peripheral resistance. Yes, I told you earlier that cardiac output is stroke volume times heart rate. Remember, cardiac output is stroke volume times heart rate. Okay, heart rate refers to the rate of contraction. Okay, and then the stroke volume, yeah, no, no, it's cardiac output that is stroke volume times heart rate. You know, I did mention the other one you said now, but no, cardiac output is stroke volume times heart rate. Yeah, okay. Remember that in respiratory physiology, minute ventilation, which is analogous to cardiac output, is what? Tidal volume times respiratory rate. Cardiac output, which is analogous to minute ventilation, becomes stroke volume times heart rate. Yes. And in this book, Essentials of Physiology, rather than cardiac output, I think they said minutes output or something. Yeah. Now, the heart rate is, if it is increased, cardiac output will be increased. If the stroke volume is increased, cardiac output will be increased. What are the factors that affect the stroke volume? Is the volume of venous return. Yeah, the volume of venous return. And of course, the peripheral resistance. Peripheral resistance will squeeze the blood back into the atrium. And so if the venous return is much, the stroke volume, of course, increases. And of course, the cardiac output is going to increase. We see that in cardiac physiology. Vascular resistance. We have just said that pulmonary blood flow is directly proportional to cardiac output, right? However, pulmonary blood flow is inversely proportional to pulmonary vascular resistance. What does that statement mean? That statement means that pulmonary blood flow is going to increase as pulmonary vascular resistance decreases. The reverse is the case. Pulmonary blood flow is going to reduce as the vascular resistance increases. We are making a case for pulmonary hypertension or against pulmonary hypertension. Because in pulmonary hypertension, what happens? There's pulmonary vascular resistance increase. And that does what? Reduces pulmonary blood flow. And that affects gaseous exchange. How? Gaseous exchange is reduced. Ventilation perfusion ratio increased or reduced? Reduced. So the pulmonary vascular resistance is low compared to systemic vascular resistance. We have said that before. And it is altered in different phases of respiration. Now, during inspiration, pulmonary blood vessels are distended because of a decrease in intrathoracic pressure. Yes, we're trying to figure this out a while ago. During inspiration, is intrathoracic pressure increased or decreased? No, we're trying to figure it out before. During inspiration, intrathoracic pressure is decreased. It's a negative pressure. That's a negative pressure. And a negative pressure is a low pressure. A vacuum cleaner suctions by what? By a negative pressure in that vacuum. You know what I mean? If the pressure in the vacuum is increased, it will not suction, it will pour out. Yes. But for the vacuum to, the pressure in the vacuum is reduced. Remember that the pleural sac exists for two reasons. One, the fluid in the pleural sac, the fluid in the pleural, not just pleural sac, exists for two reasons. One, friction. Two, to create this negative pressure. That's what it does. It creates this negative pressure. Yes. And so, during inspiration, taking in of air, the intrathoracic pressure is what? Decreased. This is highlightable information because we ourselves in this study, we're trying to figure this out. Very easy to mix up. All right. Now, because of this decrease in intrathoracic pressure, what happens to the pulmonary blood vessels? Will they shrink or will they pop? Will they distend? No. Yes. Well, this is what makes physiology. Physiology, you know what I mean? Now, how do we say this? Remember your vacuum cleaner. It takes a negative pressure to suction. When it suctions, the sac in the vacuum cleaner, will that sac shrink or bulge? It will bulge. It will bulge. It will bulge. It will bulge. It's counterintuitive. You know, it's kind of like, during inspiration now, come on. Intrathoracic pressure is supposed to increase now. You know, just forget that. Scratch that. Unlearn it. It decreases. Come on now. If intrathoracic pressure decreases now, the pulmonary vessels are supposed to decrease too. No. Intrathoracic pressure, the pulmonary vessels are going to bulge. Yeah. Once we've gotten this complicated scenario, this will cause a decrease. What we've just explained is going to cause a decrease in vascular resistance. It's very simple. Why? Because anything that makes blood vessels to bulge has a tendency to make the blood pressure to drop. Anything that makes the vascular resistance drop has a tendency of making the blood pressure to drop. You get this now? Distended pulmonary blood vessels equals decreased vascular resistance. All right? Equals decreased pulmonary blood pressure. Equals increased pulmonary blood flow. Yeah. So we're getting to the meat of respiration. So during expiration, the reverse of what we have just said occurs. So let's take the reverse. During expiration, yes, the pulmonary blood vessels are going to constrict. Why? Because of an increase in intrathoracic pressure. Are we together? This causes an increase in the vascular resistance and results in a decrease in blood flow. I hope we're not lost. No, we can't be lost. We can't be lost. We are talking of a vacuum system here. During inspiration, it is negative pressure. And in that negative pressure, there is decrease in intrathoracic pressure, inspiration. And if there's decrease in intrathoracic pressure, what happens to the blood vessels? They distend. And if blood vessels distend, what does that mean? The resistance of those blood vessels has been overcome. So the resistance drops. And what does that mean? Blood moves. In expiration, it's a positive pressure that is generated, not a negative pressure. And when a positive pressure is generated, the reverse of this happens. The intrathoracic pressure has just increased. What has happened to the blood vessels? They have just constricted. What has happened to the vascular resistance? Has gained, it has increased. And therefore, what has happened to the blood flow? The blood flow has reduced. So in inspiration and expiration, these things are taking place normally. Now, during a physiologic activity like exercise, your lungs need more or less blood? More blood. So in exercise, what happens to vascular resistance? It will decrease. What happens to blood flow? It will increase. All right? So I think we can figure our way around that drama. So nervous factors. Now, stimulation of the sympathetic nerves under experimental conditions increases pulmonary vascular resistance. Now, of course, flight, fight, fright response are going to stimulate sympathetic nerves, right, and cause vasoconstriction, all right, in the lap. The vagus nerve is going to decrease the vascular resistance and cause vasodilatation in parasympathetic. Yes. Sympathetic is fight, fright, flight, and it's going to increase vascular resistance and cause vasoconstriction. Parasympathetic is relaxation, and it is going to decrease the vascular resistance and cause vasodilatation. However, under physiological conditions, in vitro, inside this body system, we are not sure whether this happens. It is doubtful whether the autonomic nervous system play any role in regulating blood flow to the lung, because the reverse is what's going to happen in the lungs. Do you get this? Now, the chemical factors. Excess of carbon dioxide or lack of oxygen is going to cause vasoconstriction. Okay? Now, in hypoxia, which we're going to look at from this notes, where is it? Yeah. In hypoxia, now, there's vasoconstriction, and yes, in hypoxia, there's vasoconstriction, and let's look at gravity and hydrostatic pressure. Now, normally in the standing position, blood pressure in the lower limb is very high. When we discuss lower limb, we're going to be looking at the gastrocnemius soleus pump. Yes. The blood pressure in the lower limb is very high, and in the upper part of the body, above the heart, the blood pressure is very low. This is because of the effect of gravity. Why does the pressure in the lower limb need to be high? To increase venous return. Yes, now, to increase venous return. Okay. Yeah. As I was saying, in the standing position, the blood pressure is higher in the lower extremities and is lower in the upper parts of the body, above the level of the heart. Now, the pulmonary vascular pressure, however, it differs in different parts of the lung. The lung has 3 parts: the apical part, the mid part, and the lower part. Okay, in anatomy, we're going to look at the upper lobe, the mid lobe, and the lower lobe, but that's not relevant so much for physiology. What's relevant for physiology is apical portion, zone 1, mid portion, zone 2, and lower portion, zone 3. So in the apical portion, that's zone 1, it is referred to as an area of zero blood flow. It's an area of zero blood flow. And this is important in a disease condition, for instance, like tuberculosis. There are cavitations all over the lung, quite all right, but the cavitations sometimes have a preference for the apical lung zone. It's an area of zero blood flow. Now, in the apical portion of the lung, pulmonary capillary pressure is almost the same as alveolar pressure. Just know it's an area of zero blood flow, though. So the pulmonary arterial pressure is just sufficient for flow of blood into alveolar capillaries. However, if pulmonary arterial pressure decreases or if alveolar pressure increases, the capillaries are collapsed. All this long story is just to say that the blood flow to the apical portion is almost non-existent. Yes. Now, there is no gaseous exchange in this zone because we have discussed that gaseous exchange requires adequate blood flow. And what name can we call this zone? Dead space. So it's considered as part of the physiological dead space, which is ventilated but not perfused. Okay? So is the ventilation perfusion ratio high or low in the apical zone? In the apical zone, the ventilation perfusion ratio is high because it is ventilated, but it is not perfused. And so the ventilation perfusion ratio increases. So it's easy for bacteria to grow there, particularly the tubercle bacteria, making this part of the lungs susceptible to tuberculosis. That's it right there. So the mid portion of the lungs, the pressure in the alveoli is less than the pulmonary systolic pressure, but it's more than the pulmonary diastolic pressure. That complicated statement is just to say that the mid-lung zone is an area of intermittent flow. Okay, so everything in the mid-lung zone is normal. The ventilation perfusion ratio is normal. Okay, so because of this, blood flow to the alveoli in the mid-lung zone increases during systole as it should. Nothing special about that. And decreases during diastole as it should. Nothing spectacular. In the lower lung zone, however, is called the area of continuous blood flow. Here, the ventilation perfusion ratio decreases because of increased blood flow. This makes the lower portion of the lungs more susceptible to edema. So many times, pulmonary edema is occurring in the lower portion of the lung. Continuous blood flow, ventilation perfusion ratio, is it increased or reduced? It's reduced. Why? Because it's ventilated just like every other part of the lung. However, the perfusion is very high. And in some disease conditions, the blood can pool, be sluggish and slow. And as a result, there can be extravasation of fluid. And that area of the lung can get easily congested. Are we happy with this? Thank you very much. We'll see you again in another video.